This is a stylized visualization of a peripheral nerve failing to conduct action potentials. It illustrates the primary pathology of Guillain-Barré Syndrome, or GBS. GBS is a rare, acute, immune-mediated polyneuropathy that develops weeks after a viral or bacterial infection. Instead of standing down after the infection clears, the immune system responds abnormally. It misidentifies the peripheral nerves as foreign, attacking either the protective myelin sheath or the axons themselves. The clinical presentation is swift. Patients experience a rapid, ascending flaccid paralysis. This weakness typically starts in the lower extremities, often as numbness and tingling in the feet, before spreading upward into the arms and face. As the paralysis ascends, it threatens vital functions. Within days, the loss of motor control can compromise the chest wall muscles required for breathing, while damage to the autonomic nervous system disrupts heart rate and blood pressure regulation. Modern critical care utilizes advanced immunotherapies, like plasma exchange, to halt the biological attack. However, stopping the immune response doesn't automatically repair the physical paralysis. That requires specific mechanical intervention. To analyze the rehabilitation process, we examine this case. A 59-year-old male arriving at the emergency room with progressive weakness following a 2-day diarrheal prodrome. His condition deteriorated rapidly after admission. The ascending paralysis required immediate intubation for respiratory failure, while the patient exhibited profuse sweating and unstable blood pressure. Diagnostics confirmed the acute motor axonal neuropathy, or AMAN, variant of GBS. Upon ICU admission, the patient presented with flaccid tone, areflexia, and a Medical Research Council, or MRC, muscle power grade of 0 out of 5 across all 4 limbs. An MRC grade of 0 out of 5 indicates a total absence of visible or palpable muscle contraction. At the peripheral nerve level, the signal is entirely severed. Even with maximum effort, the patient cannot produce movement. To bridge the gap from total paralysis to functional independence, the physiotherapist must execute a specific 2-phased protocol, focused first on preservation and then on facilitation. Phase 1 occurs in the intensive care unit. Because the patient is intubated and immobilized, the primary physiotherapeutic goal is biological preservation. The first priority is the airway. The clinical team initiates manual chest physiotherapy for tracheal toileting and clearing secretions. When paralyzed, respiratory muscles fail to pull the chest wall open, dropping vital capacity. Without deep ventilation, the alveoli collapse, causing atelectasis. By physically compressing the thorax, the therapist maintains airway patency, improving lung compliance and preventing aspiration pneumonia. Simultaneously, the therapist begins passive range of motion exercises for all 4 limbs. Flaccid muscle tone creates an immediate biomechanical hazard. Absolute immobility causes unused muscle fibers and connective tissues to shrink, leading to joint contractures, the permanent shortening of tissue, within days. The therapist takes over the mechanical load, manually moving the limbs through full arcs of motion, preserving joint integrity and elasticity without patient effort. In the acute phase of GBS, the physiotherapist acts as the surrogate musculoskeletal system, preserving the anatomy until the nerves are capable of firing again. Preservation also includes vascular protection and deep vein thrombosis prophylaxis. Normal blood flow relies on the muscle pump action of movement. Without it, blood pools in the lower extremities, creating a high risk for blood clots, or DVTs. Foot drop splints maintain a strict 90-degree ankle angle, providing necessary tension on the Achilles tendon. This neutral position ensures the tendon doesn't shorten permanently, which would destroy the patient's ability to place their heel flat during future gait training. The fourth intervention is early mobilization, safely transferring the patient out of the medical bed. Transferring a totally dependent, tracheostomy-ventilated patient into a chair-sitting position is a complex clinical task, requiring careful management of life support lines. This movement provides critical physiological benefits. Gravitational shifts allow the diaphragm to drop, improving chest wall compliance and retraining the patient's orthostatic blood pressure tolerance. This methodical ICU preservation creates the anatomical foundation required for when the patient's nerves begin to regenerate. As nerve inflammation subsides and axons begin to repair, the patient transfers from the ICU to the ward. The physiotherapist's mandate now pivots from passive preservation to active neuromuscular facilitation. This phase introduces high-sitting and truncal balance training. High-sitting forces the patient to balance without sacral support, challenging the weakened neck and core muscles through a complex neurological feedback loop. This stimulates the inner ear's vestibular system. By processing this sensory data, the brain begins rebuilding spatial awareness and truncal control. To target the limbs, the therapist applies electrical stimulation to antagonist muscle groups. By applying external electrical currents, the therapist triggers muscle contractions that bypass the still damaged peripheral nerves. This stimulation prevents severe muscle wasting and atrophy, maintaining the hardware of the limbs while the neurological connections recover. The final phase involves proprioceptive neuromuscular facilitation, or PNF, using targeted tactile inputs. Techniques like muscle tapping, stroking, and quick icing provide high-contrast sensory stimuli that travel up intact nerves to the brain. Joint compression similarly triggers deep proprioceptors, sending critical position data. Bombarding recovering nerves with tactile data exploits the brain's neuroplasticity to reorganize itself. This sensory input provides the information necessary for the brain to remap its connections, facilitating the recruitment of newly healed motor neurons. PNF is the mechanical catalyst that translates regenerated nerve tissue into the return of voluntary movement. 1 month after beginning this targeted, phased protocol, the 59-year-old patient was reassessed. This chart tracks objective progress. In 30 days, he progressed from a 0 baseline to 2+ in the right upper limb and 2 to 3 in both lower limbs. Grade 3 is a critical threshold, meaning the patient regained strength to move against gravity. These results confirm the bimodal framework. The ICU phase protects the anatomical structure, while the ward phase facilitates neurological recovery. While acute weakness peaks early in GBS, full functional recovery and independent walking often require 6 to 12 months of sustained outpatient therapy. While medical intervention stops the immune response, the targeted application of physical stress and sensory input translates nerve repair into the return of functional mobility.